Mike. That was a really great course, and it's amazing to be back live and in person. And I'll just give a slant on my take of managing fragment that are too small for volar plating. There are certainly many different ways to manage these. Starting off really with a case example, just to make sure we're all awake. You can all obviously see that this is a displaced fracture. This is a standard management with a volar plate that's been popular for this millennium. But the fixed angle volar plates aren't the answer for every fracture. It's kind of the mantra for this discussion. So you can see this fracture is very distal, multi-intra-articular fracture fragments. Here's another one that was treated with this volar plate. Initially looks pretty good, but nothing ruins initial x-ray worse than follow-up. You can see those distal fracture fragments kind of jump over this fixation technique, which is probably predates many in this room. So the concept is, what are we going to do to try to capture some of these fractures? If we're all familiar with the volar plate complications, and you can see them listed here. If you have to place the standard volar plate too distal to capture those fracture fragments, that's not necessarily a bad idea. You just have to consult the patient and make sure you take that distal volar plate off before they really start getting their wrist motion back. While they're stiff, the volar plate's not going to cut into their flexor tendons. You would imagine it starts cutting in when they start to bring their wrist back. So that's something fine. We learned a little bit about fixation, the AO techniques here with screws and lag screws. You need effective thread purchase, stable opposite cortex, and that may not necessarily be possible with the distal radius fracture fragments, metaphyseal bone. So in this case, strong thread purchase is unreliable, as we've all been taught. Adequate implant sizes may not necessarily be possible with your standard volar plating. And we need something that's going to withstand load across the wrist. In my case, if we're doing something surgically, the goal is to get those patients moving rather quickly. Nothing pains me more than to see a second opinion where someone had surgery to fix a distal radius and then is put in a cast for 8 weeks. That's sort of counterintuitive. I think if someone's in the operating room, learn enough tricks and have enough tools in your toolbox that you can fix that bone where it's rigid, and you can start early motion with whatever technique works in your hands. For me, some of these techniques work for me, which is this super K-wire fixation that you can see here on the right. It allows for motion. Lloyd Benson looked at a bunch of these and found good results, and you can see this published way back in 2006. Again, this is sort of the concepts as they're broken down, and I'm going to skip through some of this for brevity, but radial column and the ulnar corner. This is sort of a case example, comminuted radial column fractures you can see here in a relatively young person. And plate options augmented by a radial pin plate. And sort of you've got to remember that this radial side of column is the carjack for the proximal row. This is another concept. It's the keystone of fixation. Here's another concept. You have isolated radial shear fractures, a styloid transcaphoid fracture. Dorsal shear fractures are also going to be amenable to fragment-specific fixation. Again, as we talked about, those highly comminuted intra-articular fractures. I think we're familiar with the 90-90 concept. I think this works well in my hands, where I'll fix the radial column, and then there's small fixations to fix that ulnar-sided distal radius fracture fragments, again, to maintain the lunate. And again, we're learning more and more about the value of the distal radial ulnar joint, which in years past has really been overlooked. And there's tons of papers coming out and studies talking about various ways to look at the DRUJ intraoperatively with various views. And I think that's also a high point that I don't have time to touch on today, but something for us all to start thinking about. So this is a concept. What I was taught when I was in residency is K-wire fixation, and then a splint or a cast. And then as we got, a little bit more mature in my residency, external fixation came about, and we would put the X-Fix on to neutralize the K-wires, because we realized that K-wires have this cantilever effect and basically aren't strong enough to withstand these forces. So this is sort of the concept of the K-wire. It looks good initially. As the patient starts to move, even if you're moving your fingers, there's a certain amount of joint reactive forces that go across the distal radius. And again, we can't fix these and then tell the patient not to move their fingers. We'll have a very nice X-ray, but a pancake flat hand with very little function. So we're going to try to do something to make sure this K-wire doesn't move, and fixing it to a radial-sided plate has been shown to be very, very helpful. As you can see here, the key is to make sure that K-wire somewhat perpendicular to the fracture as much as you can. You can see here on the left that construct is not as biomechanically strong, and there is a plate out there where those screws will lock in, and I've had my 1-9 union of a malunion correction because that was actually too rigid a fixation. So these are just some concepts and some cases to look at. I think we've seen this one where adding a radial pin plate to kind of close down that DRUJ. So you can put on your volar plate at times, and if you're not loving the fixation because your DRUJ is too wide, or the distal radius fracture remains too wide, you can complement that with additional fixation. You can do multiple surgical approaches, as this case would suggest. So you can do your standard FCR approach, and then you can complement it with a dorsal approach. In my residency, we were taught a little bit about making a dead bone sandwich, as it was called, where you're doing dorsal and volar approaches. And that certainly you don't want to overstrip the blood supply to any bone. But if you do limited approaches, then you're really not stripping the bone, and you can get fixation where necessary. I think we're familiar with this approach. I'm going to skip through that. And again, your dorsal incision doesn't have to be terribly large. I use a lot of fluoro in the operating room, so I get my incision exactly where the fracture fragments are. I think there's no reason not to use that to map out where your incision is going to be. I also suggest to my fellows that you take that X-ray to map out your incision. It's the best timeout you'll ever have, because if you fluoro the fracture before you make an incision, you're definitely on the right side or proper side. There's nothing better. And this is sort of the concept with these small incisions. Limited approaches. There's a multitude of fragment-specific fixation options on the market. 90-90 fixation looks like this. Moving quickly through another example. You have fixation such as this. You can see that the ulnar styloid fracture is just hanging out. That doesn't necessarily need fixation. After the distal radius is fixed, I make sure the DRUJ is stable. If it's not, then you have to manage that piece. Majority of the time, it is stable. The one caveat is I tell patients that ulnar side of the wrist typically is going to hurt upwards of 6 months, sometimes a year, but it does get better the majority of the time. This is another concept where you have little pins that will go through the teardrop, and you can manage these distal fractures. So this is a lot lower profile than a volar plate. Again, for me, this works well. There are others and wise surgeons that manage this equally well without these small pin plates. Just going through some case examples. I'm going to skip through this. The reason I threw this up here is really to demonstrate through this incision, you can go both volar as well as radial. You might have to extend this incision in a oblique fashion across the wrist joint. But you can work on either side of the radial artery with quite good results and without any devascularization of the soft tissues, as this slide would suggest, given the blood supply that's there. For me, the radial pin plate goes in this location, which is dorsal to the first extensor compartment. There's typically a bare area. I generally will release the first extensor compartment because my goal is to make the fracture as properly aligned and anatomic as possible. I've not had any tendon subluxation problems down the road, and the body will reform a little sleeve around the first extensor compartment. I have 40 seconds to remind everyone of anatomy. Just make sure if you're on the radial side, you identify the dorsal radial sensory nerve branches. and make sure that they are not irritated. It's really off topic, but I threw this palmar-cutaneous nerve because this is kind of my thing right now, is to make sure that this doesn't get injured. I don't necessarily always identify it, but I want to make sure it's there and not injured, as I've had to repair a few of these as of recent. So I think I'm going to stop there. And you can see this approach is kind of going the wrong direction, right? So the palmar-cutaneous nerve almost has to be injured if you're going in this direction. So if you're extending across the wrist crease, as Dr. Orbe has taught us all, is to oblique it radially first and then come back ulnarly for that reason. So thanks very much.